This is Mohammed Rafieetary at Charles Retina Institute. The topic of the lecture is barriers for timely detection of wet age-related macular degeneration. As we all know, the incidence rate of age-related macular degeneration is on the rise. According to the US Census Bureau, since 2010, 10,000 baby boomers have turned the age of 65. And now that we are in 2020, 10,000 baby boomers roughly are going to be turning to the age 75. So if you look at this bullet point and look at the incident rate of AMD in this age group, you can see that this estimated 200,000 new cases per year is perhaps a very conservative estimate by the NEI. So we're going to be seeing these patients more and more frequently in our practices, and we should do the best we can to diagnose and manage these patients. According to this study that was published a few years ago by Neely, a significant number of these patients having, in fact, intermediate age-related macular degeneration are being missed during regular examination by both optometrists and ophthalmologists. So we have to be mindful of this point. We all know the risk factors of AMD is a specific condition and should not be mistaken for other conditions that mimic it. There are a number of macular degenerative and dystrophic diseases, and we should be able to do a better job to distinguish between these conditions. It is a multi-etiologic disease. Aging, of course, as we said, is a big risk factor, genetic susceptibility, the environmental factors. One of the major ones that's modifiable is smoking, even though the rate of smoking since the 60s in the US population has come down. But the patient population we are dealing with now in their 60s and 70s are the ones that smoked years ago, and they're either still smokers or the past smokers. So we have to educate the patient on effects of smoking cessation. In the 1980s, during the National Health and Nutrition Examination Survey, it was recognized that poor diet is a major risk factor for AMD. And thereby, the ARED study showed that the nutritional supplements are beneficial in reducing the advancement of AMD. So this has to be considered as a risk factor. There are systemic conditions like hypertension, lipid disorders, cardiovascular disease that are risk factors. So in educating patients and assessing patients, we have to consider all of these risk factors, and we have to discuss this with the patients. Ultimately, AMD is a disease of retinal pigment epithelium, which is one of the most biologically active tissues in the body and is one that's vital for process of vision. The visual cycle actually happens in the retinal pigment epithelium, the RPE, as a result of, again, aging, oxidative stress, inflammation, the complement cascade, cell death. This tissue goes through a lot of alteration, and in AMD, this alteration in atrophic AMD with accumulation of drusen, changes in the RPE, geographic atrophy, and as the disease advances, potentially to the neovascular state by development of a vascular scar under the retinal space. All of this result in central vision loss. So we have to be well adversed with clinical appearance and the wide variety of diagnostic procedures we have to be able to detect this disease better and manage it more accurately. As we all know, the earliest indicator for AMD is drusen. Now, small drusen also happens to be a fact of aging, so it does not always mean a patient who has drusen has AMD, but if we have tools like fundus autofluorescence, we can assess these lesions better. So in this case, as you can see, this hypoautofluorescent spots that are caused by the drusen is much more detectable than the clinical appearance of this patient, and may lead into a more direction of this patient has AMD. On OCT, you can see these depositions of this uh, biologic byproduct of the retina accumulating in the retinal pigment epithelium. So drusen is starting to show up in the reflectance of the RPE. The other OCT characteristic of AMD is patients who have choroids that are thinner than normal. In normal patient, the average thickness of the choroid should be that of the thickness of the overlying the retina. But as you can see here in a patient with AMD, the choroid is a lot thinner than the overlying retina. Incidentally, this same patient with mild AMD in one eye has already gone to develop advanced exudative or wet AMD. So although wet AMD, choroidal neovascular membrane, is typically a feature of an advancing disease and disease that's been in long duration, it can happen at any stage of AMD. That's another point that we have to keep in mind when we are dealing with patients who present with wet AMD. Anti-VEGF is a very effective treatment for choroidal neovascular membrane, but we have to be mindful that this is not a treatment for macular degeneration itself, and it addresses the complication of macular degeneration in the form of choroidal neovascular membrane. Drusen itself is not a static problem. It doesn't continuously get worse. It is a very dynamic process. So here, these three line scans of the same patient in different orientation and in 1 year interval, you can see in this orientation, some of the drusen have actually started to reabsorbing as opposed to this orientation where drusen has become worse. And in this orientation, we can see alteration RPE is going through some remodeling. In the fellow of this same patient over a 1 year period, there's no significant change. So some of these disease process that is changing over time is also an indicator of a metabolically active disease. So as time goes by, we have more accumulation, larger size of drusen. This is, again, an indicator of disease progression. The fact that we start seeing high pair autofluorescence on the fundus autofluorescent imaging shows accumulation of lipofuscin, which is this pigment granules containing lipid residue from lysosomal metabolism. So this is an indicator of a diseased RPE, and the significance of these areas of lipofuscin is these are the areas that are at risk for either geographic atrophy or choroidal neovascular membrane. So as time goes by, we start seeing the pigmentary abnormalities, hyperpigmentation, RPE loss, and geographic atrophy. Here you can see the release of the melanin and the deposition of it in the intraretinal tissue. All of these are, again, indicator of disease progression, a patient potentially leading to developing choroidal neovascular membrane. Geographic atrophy is a significant factor in central vision loss and functional vision loss. And roughly as many patients who develop choroidal neovascular membrane develop vision loss from geographic atrophy. So here is a patient, again, on the fundus autofluorescent. We can see hyperautofluorescent, and the same areas over a 2 year period has resulted in geographic atrophy. Here, a patient with significant GA that may still have good Snellen acuity, but has functional vision loss because of the perifoveal tissue loss that you see here. So in summary, staging AMD, we start with early AMD with small and intermediate drusen to intermediate AMD with intermediate and large drusen, and then advancing AMD and advanced AMD, which is defined by either any degree of geographic atrophy or choroidal neovascular membrane. So what are some of our failures in detecting wet AMD? One is from the patient perspective. Many patients, even though with advancing disease, remain asymptomatic. Part of this is failure of monitoring monocular vision. Even though we educate patients to do this and using either grid or other methods, patients forget this after a while. Vision is a very complicated perceptual issue. It doesn't happen in the eye, it happens in the brain. So there are many factors. For instance, here we have an image that's not complete, but by just some visual cues, we all know this is a cow. So when we see things, they don't always appear as they are. And this complicates the issue as far as a patient knowing something's wrong. There's this lack of understanding. It's like patients you see in the clinic where you ask them, how are you doing? How's your vision? And they reply by saying, well, I'm here for you to tell me, doctor, how am I doing or how am I seeing? I told the patient one time that if I were a shoe salesman, would I be able to tell you how comfortable those shoes are on your feet? So you have to tell me how you're seeing to be able to understand your disease process better. Or patients who say, well, your technician told me I saw the chart better today. Or when you tell them, call me when you see a change, they ask you what the change is. So you have to educate the patients that there's really no specific change. They are the user of their visual system, so they have to looking for things that may not appear to be normal. As far as reliance of things like antler grid, which is an anti-curated testing, there are a lot of flaws with it. There's this flaw of, again, completion. Here is an optical illusion where you can see the triangle, even though it's not a complete image, because our brain again takes over. There is an issue of fixation. You have the patient fixate here. If there's a flaw in this chart, the patient constantly wants to look at that flaw and it keeps moving. So it causes a lot of confusion, and then again, this issue of compliance. You tell the patients to do daily Amsler grid, and what happens is they come back and say, well, I moved and lost the grid, or I don't know where it is. So we have to do better by this patient. So here, as an example of, relying on patient symptoms. This is established patient with a disciform scar that's long standing in the left eye. So this patient is pretty much centrally monocular. So you would assume if there's a change in the right eye, the patient would know. They're coming back for their follow-up examination with no additional um, symptoms, although this eye shows a small hemorrhage and the OCT shows a choroidal neovascular membrane. So the patient is already converted in the fellow eye unknowingly to wet AMD. And here, to prove that this is a choroidal neovascular membrane, is 1 month after an injection, where you can see partial resolution of the CNV and resolution of the fluid. So this is a big challenge for the patients not knowing what's going on. Here, so from the point that this process begins and shows up on the Amsler grid that the patient might give you a clue, the therapeutic window has been gone, so we have to catch these patients at these stages as opposed to here. So if a patient starts with the extrafoveal CNV and time goes by the time they come back in 6 months, this thing has become a large subfoveal tissue. And a number of studies, this was the CAP trial, was studied years ago to see if subthreshold drusen treatment can help with progression of AMD, which did not pan out, but they looked at the regular monitoring of vision as opposed to intense monitoring of vision. And you can see if patients are just, going by regular monitoring and periodic visits, by the time we get them, only 20% of them have 20/40 or better, and 80% of them have subfoveal lesion. As opposed to that, if we do intensive monitoring and follow-up of this patient, we can catch them at much better, situation. This is a recent study that was published in JAMA Ophthalmology that again shows that patients' adherence to follow-up is very important for their visual outcome. So patients who miss appointments and do not comply with follow-up care have loss of vision. barriers of detection based on us doctors is, again, reliance on the patient's symptoms and presentation and follow-up. Reliance on visual acuity, the Snellen acuity is a bad way to manage patients who have macular disease. Reliance of classic clinical appearance, and some of the reliance of our technology. So studies have shown that if we don't give this patient, keep these patients on tight follow-up schedule, the longer the distance between the two visits, the more advanced disease they will be going to present with. So as far as Snellen acuity goes, we have to compare it to this concept of vernier or hyperacuity. So hyperacuity is our ability to discern separation of two objects in space, and the brain is very sensitive to detect this. So if you compare this to Snellen acuity, which is discerning clarity of a letter at certain distance, you know, it takes a minute of arc for separation for us to detect these letters, whereas in separation of two lines, well, all it takes is 2 seconds or 0.03 minutes of arc to be able to detect this separation. So this is a concept behind how calipers are much more um, sensitive to measuring very tiny amount of, you know, distance between two objects, as opposed to using a ruler per se and trusting our eyes to do this measurement. So as far as clinical appearance, we always think a patient with wet AMD is going to show up with a hemorrhage or some detectable lesion. But here is a patient that on clinical examination appears to have dry AMD. Even the FA is not that impressive, but when you do OCT, you can see that there's wet AMD has already developed in this eye of the patient. So, and then when the patient gets to that point, then the disease becomes chronic. So this is the same patient, been treated for a number of visits over a 6-month period. They are somewhat stable with some activity, but the patient refuses treatment and come back 3 months later with a reoccurrence of a very large choroidal neovascular membrane. So compliance even at that stage is much more difficult. Here, the reliance of OCT, which is very effective in managing this patient. So this OCT of a patient who's never been treated does not really reflect a choroidal neovascular membrane, but if you look at the OCT-A of this patient, you can see there's a choroidal neovascular membrane. So detection of this disease in some patients is very difficult, even with good technology. There are some simplified risk factors. So this is one that's good. So if you're seeing a patient with having this, either large drusen or pigmentary changes, you can give a score of 1 to each one of these. So a patient that has neither one of these has a 0.5% chance of developing CMV over a 5-year period, as opposed to a patient who's got all 4 of these has a score of 4, which has a 50% chance. So presence of this will give us a clue to follow up and monitor these patients better. But again, as I said earlier, you could have none of these, could have small drusen and still develop a choroidal neovascular membrane. So if you have a chance of something, it could happen. So what can we do? Patient education, nutrition, nutritional supplement, vigilant follow-up, and newer technology that is available to us. So, you know, one of these is home monitoring. Now, home monitoring of certain things is not foreign to patients. So we all know a smoke detector is much better to detect smoke in our home than our noses. As far as medical problems, patients are, you know, used to having home monitoring devices for temperature, blood pressure, sugar, and now even EKGs. You know, cardiologists recommend watches that patients can wear to monitor their EKGs either remotely or by bringing the data to the office. So we have the same sort of technology to look at variation and changes in the photoreceptor. So a patient who has shift of photoreceptor is going to have some distortion of vision. And this instrumentation, the 4C home device, the PHB device, can detect these changes. So what this the preferential hyperacuity perimetry pretty much is detection of distortions in a line. So what happens is lines of varying degree of distortion is presented in the machine, and the patient is asked with this mouse to click on the distortion point they see. So if a patient has developed a choroidal neovascular membrane or a large drusen or what have you, if that distortion point is larger than the arbitrary one shown by the machine, the patient is going to prefer that. They're asked to click on the larger of the two bumps in a line. So they're going to pick that. And as they pick these lines, a metamorphopsia on macula map is provided that looks like this. So these couple of uh, examples I'm going to show you is based on some of the work I've done with the office device years ago, because the home device is not approved for wet AMD, it's approved for intermediate AMD. So I don't want to confuse this situation, but just to show you how the technology works, this is an example. So this is a patient with the choroidal neovascular membrane and thickening of the macula here. So you can see the metamorphopsia map with this very dense area. As the patient gets treated, you can see that that dense area goes away. So you can extrapolate this backwards. So if this is a patient with intermediate AMD like that, and this is their map, if the map changes to this, you could suspect some changes that has happened that's due to wet AMD. So another patient in both eyes has choroidal neovascular membrane. So you can see the metamorphopsia map here, and you can see the change of this map over time when the patient is treated and the fluid is gone. So this is a very sensitive way of detecting metamorphopsia, which could happen with large drusen and distortion in the photoreceptor lines. So here the AI will detect changes in this. So what is the 4C home device used for is patients who have visual acuity of 20/60 or better, and patients have the diagnosis of intermediate AMD. So those are patients who have either intermediate or large size drusen, but have no geographic atrophy or choroidal neovascular membrane. Another group of patients, this is very helpful, is a patient who's already converted in the fellow eye, and one eye has intermediate AMD that's at risk for developing wet AMD. So what happens is this is the pivotal point of the Notal Vision clinical service. After we send the prescription request for a patient, the patient is contacted, a device is loaned to them, and it's sent to them. They are trained by professional technicians. After the test based on is established and they know that the patient is capable of doing this, we recommend daily testing. So it takes over the patients trying to figure if they have a change in their vision, as opposed to both AI and qualified physicians, certified ophthalmic technicians looking over the test results to make sure the patient's daily testing is consistent. And if there is a statistically significant change that happens in one eye or the other, then the referring physician is alerted to this, and we can call the patient and have him come in. So this is very important. And we also have either through a secure portal or even on my phone. I took this picture from my phone where I can go on the app and look up my patient's name and see their testing patterns and see their maps and decide for myself if the patients had a significant change that they have to come in. But again, I don't have to rely on myself. The diagnostic services of Notal will alert me if there's a change in my patient's visual behavior. So as far as pros and cons, yes, ODs can prescribe this. It is FDA cleared. It's covered by Medicare. You know, they will give us clinic support. You know, they send the reps from Notal Vision to talk to us. If you have any questions, they answer that. And you know, do we have to buy this device, or does the patient has to buy it? No, they lend the device to the patient. You know, for office use, they help the patients with getting them hooked through internet, or provide internet services, or help the patient with that. Is the reimbursement for us to look at this? No, still no reimbursement. But if it generates an office visit or what have you, we are still able to, you know, the file for the visits and the imaging and the examinations we do at our offices. So in conclusion, AMD very common. 10% of the patients with AMD go on to develop choroidal neovascular membrane and wet AMD. Sometimes it can be challenging to diagnose these patients. Anti-VEGF is extremely effective in treating these patients, but delayed, you know, detection also results in poor diagnosis. So in the old days, we used to see patients like this because we couldn't do anything about them. These days, with anti-VEGF, we can save a lot of, you know, bad prognosis, patients' vision, but we have to detect them earlier. Most studies show that if you catch the patients at early stage, you know, of the disease, you have much better outcome than when you catch these patients after they've gone to 2200 count finger vision. Even though you could perhaps improve the vision, but you never bring the patient to some degree of functionality, particularly in, you know, driving. These patients want to stay independent, be able to drive. And if we let this disease go on for sometimes, as far as choroidal neovascular membrane, we can never bring them back to that functionality. So, then again, most studies that have been published show that the significant number of patients, by the time they come to the, you know, to the table for treatment, they've lost vision. You know, their vision is worse than 20/40. So can we do a better job? Of course we can. We have to use all of our tools in our hand, and one of those tools is the 4C Home. I would recommend you to contact 4C Home and Notal Vision and see if you can implement this in your office. Thank you all for your time. I hope you enjoyed this presentation.